Hi, everyone. My name is Cheryl Cohen. I'm with Arthritis Consumer Experts, and I am hosting this hashtag #CArthritis interview with Helene Alexanderson. Welcome to the program.
Thank you so much. Great to be here.
May I call you Helene?
Absolutely.
Thank you. For our audience, Helene, you're an associate professor and physical therapist at the Karolinska University Hospital and Karolinska Institute in Stockholm, Sweden. You presented at this year's Canadian Rheumatology Association and Arthritis Health Professions Association annual scientific meeting, and your focus was on muscle weakness and myositis. And those are, as we say in English, kissing cousins. Those two things, by definition, if you're experiencing myositis, you are very likely experiencing muscle weakness. You've conducted research studies on muscle endurance, muscle strength, and exercise as a treatment for myositis, which is really interesting. I know that's not a garden variety term used on the street every day by the general public. So I thought, Helene, where we would start is just two things. Tell us why you got involved in rheumatology. What was it that lured you as a young undergraduate student into the area of medicine, and specifically physiotherapy, with a rheumatology focus? And then two, give us just a really high level. I know it's a complicated topic and likely a week-long course in and of itself just to say what is myositis. So let's start with those two things.
Okay. So I graduated from a physical therapy school at the Karolinska Institutet in 1991. And then I was so sure I was going to work with stroke patients. So actually, that's what I did for my first 2.5 years. But then, I had a long commuting to my workplace from where I lived. So I just contacted Karolinska and asked, do you have anything? And they said, yeah, we have an opening 2-month position at the rheumatology.
That was back in 1991. So 2 months stretched into quite a few years.
Yeah, 1993, that's when I started at rheumatology. And that's where I got stuck. I really liked it because there are similarities in physiotherapy between stroke patients and patients with rheumatic disease, because everyone is so different. You have to really look at the individual and together with the patient come up with, well, what are your goals and what are your limitations? So I found the same thing that I found in stroke and neurology. I found it in rheumatology.
Rheumatology, yeah. And then when you think about that, those two types of patients, though I'm a rheumatoid arthritis patient myself, I obviously have met many people who have had stroke and who have undergone many challenges trying to get back their motor function, their strength. And it's interesting from your side of the lens, it really involves a lot of communication, doesn't it? In this goal setting and what do you want to get out of this life now that you've had a stroke or now that you've received a rheumatology sort of diagnosis. So lots of communication, I imagine.
Absolutely. And so when pretty early, already in 1994, I got in contact with Professor Ingrid Lundberg, who is a rheumatologist and who got a myositis clinic started at the Karolinska. And so I got involved in a project. It was actually on creatine supplementation in RA.
Oh.
So I did some assessments in that study. And then she had this patient coming with myositis coming into her office, and she had told him not to exercise. But actually, he had done some exercise, and he came in and did, push-ups on the floor. And so she started to think about, well, why can't these patients exercise? So she contacted me and said, well, would you like to develop an exercise program that we could test in myositis? So that was kind of the best decision I made.
You know what? It's interesting. While we have a bias as a patient organization, Helene, we always say if you follow the patient, they'll take you in the right direction, right?
Absolutely. Yeah, we learn so much from you all. So myositis is it's kind of an umbrella name of a lot of similar but also different kind of autoimmune inflammatory myopathy. So we actually believe that the immune reaction starts in the lung.
Oh.
But I mean, muscle weakness and reduced muscle endurance is kind of a cardinal symptom for myositis. Most patients with any type of myositis have some limitation in muscle function.
So they're going to experience maybe trouble walking upstairs or getting out of the chair, like really simple stuff.
Yeah, and it's usually the proximal muscles, so they can have problems lifting their arms above the horizontal plane.
Okay.
They get weakness in the neck flexor muscles, and it's the hip flexors and the quadriceps.
Okay.
But we've also seen that patients with polymyositis and dermatomyositis, they have pretty much, rather much reduced grip strength as well. So it's not only the proximal muscles, it's also distal muscle groups. But over the years, we have, they have discovered many different autoantibodies that they have been able to connect to clinical profiles in myositis. So before we had in adult patients, I only see adult patients.
Right.
We had polymyositis, dermatomyositis, and inclusion body myositis. But now we have antisynthetase syndrome, so that those patients who have an myositis-specific autoantibody. And usually they have a lot of lung, interstitial lung disease.
Right.
And they might have muscle function problems or not. So it could differ. Some have more muscle and some have less muscle. And then we have dermatomyositis with specific autoantibodies, and depending on the...
Does the first part of that word derma give us a clue that it also involves some skin?
The skin.
Issues? Yeah. So what I'm hearing from you is definitely this, it's myositis is a snowflake. So every person or patient is going to present perhaps somewhat differently. Is it common, Helene, for someone who goes on to get a myositis diagnosis of one of these types that you're referring to, do they typically have one of the symptoms, multiple symptoms? What's the most common, though I know nothing is common in a more rare type of arthritis like this?
Well, I mean, if you have dermatomyositis, you usually have some...
The skin.
The skin in some degree. If you have an MDA5 autoantibody, you have a lung disease. But if you have the MI2 antibody, you will mostly have muscle disease. So it can, you can have a myocarditis, like inflammation in the heart muscle.
Right.
So it's difficult to say. It's going to be, you can have 5 people with the same autoantibody and the same myositis diagnosis, and they will present
very differently. But the cardinal one that you're talking about is this proximal strength issue.
Yeah,
like the lifting above the head. Yeah. When we think about myositis then and muscle strength, and specifically the presentation that you gave at this year's meeting, give us a quick Cole's notes on that. What were the big takeaways for the audience, which the audience were your peers, obviously, as well as rheumatologists themselves?
So, I mean, there is so much we don't know why the muscles become weak. So we think, you know, it all starts with inflammation.
Right.
And that will induce changes in the contractility of the muscles, and also we think that it will induce metabolic changes. Like there is this phosphocreatine in the muscles that is very important in the citric, I think you call it citric acid cycle.
Yes.
Yeah, for the muscle energy. So if you have too little of the phosphocreatine, then you won't be able to create ATP that is very important for muscles to be able to go on exercising. But then we've also seen reduced number of capillaries in the muscles. So maybe the muscles don't get enough oxygen to be able to work for a long time. And so we've seen a lower number of capillaries in the muscles.
So the itis part, the inflammation, is causing these multiple types of disruption in the muscle tissue, including fewer capillaries, meaning less oxygen. And so this constellation of factors, you feel, are the reason people experience muscle weakness.
Is one key. We have all these beats of puzzles here, and then we get to in here. It all, so the big challenge is to kind of connect them together and understand where does it start and what happens then, and when do these changes happen? Are they there already before the diagnosis?
Oh, okay.
That we don't know. So we mostly have done studies in patients who had their disease for a long time. They've been treated with corticosteroids and immunosuppressives. So we don't know what is the disease itself and what is effects of the medical treatment and what is physical inactivity.
Okay.
So we know what happens if you don't exercise. You're going to lose muscle mass and a number of capillaries, and you're going to get weaker.
So the old adage, if you don't use it, you lose it, applies to myositis as well.
So that we know from a lot of research in space, and what there are lots of studies on people they tell you, go to bed, stay there for a week. And
31 years ago, Helene, I was told that. That's what I was told 31 years ago. And you know what? As a patient, I broke the rules. I just said, no, I used to be a high performance athlete. I'm not going to stop riding my mountain bike. I'm not going to stop trying to go to the gym. And in actual fact, it was the best thing that I had ever done for myself, was kind of quote unquote break my physiotherapist rules. And then together, like with your patients you described early on in your career, you learn together, which I think is it really underscores the importance of the research that you do. As well, the participants who come into your research program, you couldn't do your work without your patient partners in this endeavor.
Absolutely not. We're I think.
Let me ask you, this might end up being a sobering question for our audience and likely for me as well. You use the puzzle as a metaphor. So if we stick with that, how complete is the puzzle in terms of complete knowledge of myositis? Why, where, when, how? What would you say? How close are we to finishing the puzzle?
It's impossible to say, but I think we're quite far from understanding the whole picture, and especially when we talk about the recent onset, what happens early in the disease. So that's actually what we're studying now in a study in recent onset myositis. We take the muscle biopsies very early for diagnostic purpose. Then they go into a randomized control trial. They do high intensity interval training with intensive resistance training as well. Or they go into this more moderate, easy home exercise program that I developed in the 90s. So it's going to be very interesting to see, to more study in detail, what are the pathology in the muscle that early, before patients get treatment, and how can we see what happens if you do intensive exercise? Is that safe that early on in the disease? Can we see any differences between these groups in the long term on how they're doing, how much corticosteroids they have, how are their aerobic capacity and muscle function and quality of life and fatigue?
All of those good things that are outcomes. Yeah.
And I think just to mention inclusion body myositis as well.
Okay.
There's a lot that we don't know. What happens in the muscle? Why do they lose the muscle mass and muscle strength? And because it seems like IBM patients present very differently from the other adult myopathies.
Why is it that I'll start over here. Is it that in early myositis, you lack data because it takes a long time for someone to get a diagnosis? Is that, and so by the time you see them, they're clearly, obviously desperate for treatment, have been treated in some way, and then you're not really ever getting early disease. Is that a true statement or not?
I mean, it is a problem that it takes a long time for patients to kind of reach a rheumatologist and get the right diagnosis. Yeah. And in a few cases, they have been treated with corticosteroids, so it's difficult to see. But we do have a lot of biopsy material from treatment naive patients. So I think it's just deciding to start to dig into it.
Yeah. Okay. I mean, I imagine your field, that you don't number in the thousands who specialize in this area of research, I would imagine. So research capacity is clearly something that we would need to pay attention to in a disease such as myositis as a general term. Let me ask you, when you think about, as you see patients, so you know this as well as I do as a patient myself, when you're given a diagnosis, any kind of itis diagnosis, so an autoimmune or an inflammatory type of disease or condition, you get a tremendous sense of loss of control, Helene. You really do feel out of control, that you don't have control over your daily life. And we do everything we can to seek out information that will help us, that we can use ourselves. What is it that you tell your patients about lifestyle, about self-care, about self-motivation, self-learning? What is it that we can do more of or better at to help us manage or care for our own disease as we're trying to enhance or regain quality of life?
I think it's very important aspects that you bring up. Well, of course, I talk about physical activity, exercise with everyone. When I see a new patient, I always ask, so what did you do before it happened to you? And because there are studies showing that if you used to have a physically active lifestyle before you got this autoimmune disease, it's pretty likely that you will continue. With the right support, you're gonna get started again.
Yeah.
It gives me a lot of information. Okay, so this is someone who used to be physically active. So then in their mindset, they're already there. They wanna get going.
So in other words, their state of readiness is high.
Yeah. And you're reading there's all this information on the internet, and some of them has already found some exercise program that I posted on the Myositis Association website. And there's so I used to do this. What can I do? Will I be able to go jogging again or play tennis? I'm very careful to say, so okay, you shouldn't forget any of these things that you used to do. You can get there again. It's gonna take a long time.
Yeah.
Maybe you need to see a year from now before you can actually And it depends on how you respond to your medical treatment, depends on your pain level, on what fatigue levels you're going to have.
Yeah.
I also say, so I'm going to be here for you. I'm going to see you. I'm going to give you an exercise program. I'm going to follow you closely over the first year. And then I see patients every year or every other year. And I talk to them about this physical activity, exercise. What are you doing? What are the barriers for you being physically active? What are the possibilities? And kind of follow patients' mindset from the beginning of the disease. I mean, it's a trauma.
Yeah. Yeah, you have to get, I mean, most people do go through a denial phase. You have to get through that. You have to come to acceptance. I mean, it's all part of that patient activation scale, right?
But I also talk about sleep. I talk about pain and fatigue, smoking.
Does smoking make myositis worse as it does in other autoimmune types of arthritis?
We don't have that much data.
Okay.
But I mean, smoking is never good for anything.
Yeah. And it stands to reason, like if you were just to sort of be armchair scientific quarterback, if you believe there's some origin in the lungs for myositis, it stands to reason smoking's not going to be that great. May it even be causative, do you think?
I think there is some data suggesting smoking as a risk, as one risk factor.
Okay.
To develop myositis, since we believe it's the immune reaction often starts in the lung.
Yeah.
So it makes sense.
Yeah.
But then we don't have all the data that we have in rheumatoid arthritis.
Yeah.
But I work very closely with occupational therapists.
Okay.
So almost all patients see an occupational therapist and talk about their hand function and pacing, finding the balance between activity and rest, and what assistive devices can they get to kind of make life a little more simple in their household work. And
yeah, that reminds me to ask you, Helene, age of onset, what's the range typically?
I think the mean rate of the onset is maybe 50, 55.
Okay, so still working life. Yeah.
And, we have very young adults from 18 up to, I think I just saw a patient who's 87.
Wow.
So and then we have the kids, the juvenile.
Yeah.
Well,
it's interesting for the sake of our audience. Occupational therapy doesn't necessarily mean you have to have a paid occupation. It can be a child wanting to run around the playground with their friends. That, for all intents and purposes, is their occupation at that point in their life.
Yeah. So I think occupation, that word is more like all the activities that you do.
Yeah, functional. Yeah.
Functional. So it can be related to your family life or your working life or your domestic life or gardening or all activities that we are doing every day.
Let me ask you, Helene, we've obviously been living through a historic pandemic, regrettably. We know how it has disrupted healthcare on a grand scale around the world. We are obviously very indebted to health care professionals such as yourselves for standing the front lines, for doing all that you can. How has it impacted both your research program and the care of your patients throughout COVID-19 era?
Well, I think, when this started a year ago, the clinic and research just shut down.
Yeah.
That no one should come if it wasn't like a life and death situation. It wasn't really an emergency. So then, we started to have a lot of telephone calls and telemedicine with video visits. But of course, the quality of the care and, our ability to reach out of new patients seeking care, I think I don't think that we will know the impact of that.
Right.
Right. That
just like we won't know what the impact is on the lack of education, in-person education for children over a period of time. And I know Sweden took a controversial approach, I think, to COVID-19 management, you know, with maybe early success and then early, you know, later criticism. And it's been a hodgepodge around the world. So it's been very, very interesting. Last question for you. When you think about your field in a research, you know, just through your research lens, Helene, kind of what are your next steps? What do you think are going to be key milestones for maybe not just your own research program, but for research in general in this area? Our viewers, our members, our subscribers are always sort of riveted to the words of people like you who are at the leading edge of your field. What do you see as the next sort of big advances?
And then you're talking about the whole.
Yeah, in general, and then perhaps a comment or two about your own field of research. What's your next big goal?
What's in myositis, it's still we need to learn what is the optimal type of exercise and physiotherapy for the different subsets of myositis. And then we have the other inflammatory systemic diseases like lupus and systemic sclerosis and vasculitis. We don't know anything at all about vasculitis. I think for me, the interesting thing is what can we do about pain, like pain levels, and how we know that some patients with RA and other types of rheumatic disease, they cannot develop this widespread pain issues. And so I think that is one field of understanding more about pain and how can we treat pain. I think the field in the systemic diseases is going to go in the same direction as they have done with RA, to understand how can people take care of more self-management, community-based exercise, and this rehabilitation, multi-professional rehabilitation programs, the cost effectiveness of physiotherapy, occupational therapy.
Yeah, you know, these things you're talking about, I know that in Sweden you have a very robust healthcare system that offers much of what you've discussed as part of your services that you offer. So in other words, free, but we know it's not free because you're paying it in taxes. But you know that the barrier, particularly in North America and in underdeveloped countries, is cost. And patients can't, you know, see a physiotherapist because they can't pay for it, or the system itself doesn't have that service baked into it. So for someone who is living in that environment, people who where inequity, they face inequities every day. Racism in the healthcare system, big issue, obviously today, something that we're very concerned about, especially in our Indigenous people's patient population. What would you say about inequity in general in physiotherapy access? How is it your community is addressing that?
Well, in the field of myositis, we are currently, we have gathered through the international collaboration, the International Myositis and Assessment Clinical Studies Group. That's a mostly physician-driven research collaboration, kind of focusing on improving clinical assessment and clinical treatment and kind of pushing the boundaries forward in knowledge in myositis. So in this, they have a rehabilitation and exercise scientific interest group that I'm chair of, and we're currently writing consensus exercise guidelines.
Okay.
all patients with myositis, and so we hope that we can really get the message out that it's safe.
Yeah.
Everyone with myositis can exercise. You just have to adapt it to your disease activity, your corticosteroid doses, how much pain and fatigue, and your muscle function. So that is because it's still a fear in many countries and with many physicians, it's still a fear that exercise might harm.
That I'm going to do something wrong if I go out and exercise.
Yeah. So that's what we're doing in the field of myositis. And I know that there are similar endeavors for other rheumatic diseases. So I think I'm also looking at the health benefits of physical activity and trying to understand how we need to know more on how maybe we can prevent some types of autoimmune diseases. Or
I love that word. Everybody's going to love hearing you say prevention. That's amazing. Yeah. Not many do, Helene. Like not many in your field or in the field of medicine use the word prevention in these types of autoimmune diseases. So I'm very encouraged to hear you say it.
Well, I think that, I mean, in RA, there's a lot of research going on to try to prevent this, to find it so early that you never develop any symptoms.
So secondary, but so early secondary that it becomes primary. Yeah. No, that's fantastic.
So, I mean, there is a good epidemiological study in RA showing that if you were physically active before your RA, then you're going to have a milder disease. And I mean, if we can show that if you're physically active, you're going to have a milder disease.
Yeah.
Or before you develop an autoimmune disease. So I think there's a lot of potential in this very cost-effective treatment called
exercise. Yeah.
So in the right dose, you're not going to have any serious side effects.
I think this whole concept of exercise is medicine, and if we can put that message into lay language, accessible across barriers that have created inequity in our world of healthcare, that would be fabulous. You know, Helene, I could go on and on and on and keep you in conversation for hours, but I am cognizant of the fact that in Sweden, it is approaching dinner time. And I really appreciate the time that you've taken to speak with us. Thank you so much for being such an excellent presenter at this year's annual scientific meeting, and for joining our #CArthritis project. We so appreciate your time. We will look forward to getting comments from our audience. If we have any questions we're not able to answer from our own resource pool, we'll certainly reach out to you to satisfy the information needs of our viewers. So thank you so much.
Thank you. Thanks for having me. Yeah, it was my pleasure.
Wonderful. See you soon.
See you. Bye.